Good afternoon, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled The Opioid Crisis and Emergency Department Intervention. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Tuesday, April 30th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. I now would like to introduce our presenter, Dr. Mark Stavros. Dr. Stavros is board certified in both emergency medicine and addiction medicine and is a fellow of the American College of Emergency Physicians and the American Society of Addiction Medicine. Dr. Stavros received his doctorate of medicine at Creighton University and completed his residency in emergency medicine at St. Vincent's Emergency Medicine Residency Program in Ohio. He is currently the medical director of the emergency department at West Florida Hospital in Pensacola. He actively works in addiction medicine with several organizations throughout the country. He serves as the education director in emergency medicine for the FSU College of Medicine and is the medical director of the EMT paramedic program at Pensacola State College. He also serves as one of the peer mentors for the Florida Alcohol and Drug Abuse Association. And now I'd like to welcome our presenter, Dr. Stavros. I will turn the presentation over to you.
All right. Can you hear me okay?
We sure can. Thank you.
Fantastic. Well, thank you very much. I want to say thank you to FADA and for DCF for allowing this to happen and for inviting me to present this information. We're going to go ahead and jump in. There's a lot of information here, and I'm really happy that we're going to be able to give you this information afterwards in a slide deck, so that'll be great. All right. Obviously, we're going to talk about, you already had the title there, the opioid crisis and the ER intervention. You know who I am. Let's move on and talk about some of the objectives as well. So by participating in this webinar, really what I want to discuss and hope we learn a little bit more about the opioid crisis. If you don't know about the opioid crisis, you may have been living under a rock because that seems to be on the forefront of everybody's TV and everywhere you go. It is a big deal going on, and we'll talk about that. We're going to talk about understanding about addiction and how the medications that are used for opioid use disorder work. Also talk about how it's important to initiate medication-assisted treatment and some of the support services in the emergency department, and also be able to discuss some concerned realities, solutions for initiating MAT for opioid use disorder in the hospital emergency rooms as well. So opioid crisis, obviously it's a big deal. It just seems to keep getting worse and worse despite some of the things that we put in place. In 2017, there were over 70,000 overdose deaths. That's 9.6% higher than 2016. As you can see below, 1999 compared to 2016, there's a heat map, and you can see just a huge change. Anything that's red, that means it has over 30 plus deaths. And so you can see across the country, back in 1999, there's just a couple little red and orange areas, not much, but now you can see quite more across the United States. So obviously it's gotten much worse over time. What are some of the drugs that are involved? So, obviously prescription medications have been really talked about quite a bit as part of the problem. And in Florida, we've had some changes with the House bill and having an understanding that doctors may be prescribing too much. Let's get a handle on that. As you see that prescriptions start to plateau off after about 2013 and really starting to get control over the next several years, we think, hey, we're getting a handle on this. But what happens is opioid use disorder, that person is going to, it just doesn't go away because they can't get a prescription. They're going to seek other things. And what do they seek? Well, they're seeking things like heroin and fentanyl that are on the street. And the problem with heroin and fentanyl, they're just so much more potent, so much more dangerous that the death rate continues to climb, exponentially, even compared to the prescription crisis that we had. In Florida here, just alone from 1999 to 2015, and as I spoke before about the prescriptions kind of leveling off, what is taking over? This slide shows as well heroin and the non-pharmaceutical analogs such as fentanyl start to take over while the prescription medications seem to go away, or at least start to go down somewhat. Part of the problem is an understanding about, and I don't think we do a very good job following some of these patients. So here's a slide. This is from Nora Volkow, who's the director of NIDA, National Institute of Drug Abuse. And she shared this a while back, and I thought this was fascinating that, here's 91% of the patients that had overdosed still were receiving opioid medications after their overdose, and 63% of them were still on high-dose opioid medications 31 to 90 days after overdosing. So it's remarkable that, a doctor is still going to say, hey, I'm still going to give you those opiate medications, the same ones that you just overdosed on, and we're going to keep you at that same dose. And that's very worrisome. As you can see here, 17% of the high-dose patients overdosed again within the next 2 years. And so we needed to have some education and get a handle on the prescription medications. Opioid-related emergency room visits in the Florida alone increased 32% between 2009 and 2014. Nationally, there was a 99% increase between 2005 and 2014. In the U.S., there's 146 deaths a day in 2016. 60% of those are from opiates. And as we saw in 2017, that's even increasing. It's over 120 deaths a day that are opioid related. Now in Florida, at least, we have at least 14 deaths a day, and probably higher than that in 2016. But remember, for every death from an opioid overdose, we probably have somewhere between 25 and 30 other opioid-related non-fatal overdoses as well. What's the cost? Well, the cost is astronomical. Illicit drug use in the U.S. is estimated to have cost the U.S. more than $750 billion. That's from loss of productivity at work or healthcare fees, the cost associated with criminal justice system. And only about 5% of that cost is actually going towards treatment. And so if we've introduced medication-assisted treatment, we've shown that we've been able to significantly reduce those costs, and we'll talk about that in a little bit. I think it's important to understand addiction and really how it works and how we need to view it. Oftentimes we've seen it as bad behavior, it's a behavioral disorder, but there's so much that has to be understood about the science of the brain. So we've done a lot of research. We have realized that there's actually a disease process going on. This is a chronic disease, and we know that it affects the brain. So the organ that's affected in this disease process is the brain. It's a disease of brain reward and motivation, the memory and related circuitry that go along with that. And there's a dysfunction of that circuitry. And we know that there's cycles of relapse and remission. And we know that it can result in disability or premature death. So this is not unlike other chronic diseases such as diabetes and asthma and hypertension. We'll talk about that too. I don't think we can stay on that slide. There we go. So the areas of the human brain that are especially important, just to understand briefly, is really the reward circuit that we're talking about. And in the basal ganglion, a couple little important areas are called the nucleus accumbens and the ventral tegmental area. And those areas are really important to help us understand what we do to pursue goals and gives us motive to go towards something, to experience reward. And we're going to talk about dopamine. And dopamine is really that neurotransmitter that seems to be that driving force that is stimulating that nucleus accumbens. And the supply to that is from the ventral tegmental area. We like to call that the VTA. And dopamine goes to the nucleus accumbens and says, hey, listen, this was something we need to remember, and we need to pursue it. And it gives us some type of rational thought of saying, listen, we need to do that because that's important in our life. And we're going to talk about the salient point and really what's important in life. So that limbic system kind of controls those basic needs as eating and drinking and mating and protecting children. Those are good things to have our brain functioning, but we have to have that within reason. And so the prefrontal cortex in that green area, that's that area that starts to develop that says, hey, we need to have good decision making. We need to have reason. This is where we learn. We have good thinking skills. And the other aspect of that midbrain is the extended amygdala. And that's that stress response area, that fight or flight, and that helps regulate those negative emotions. And this is where we've seen stimulated on MRI scans or PET scans, basically, of where we see withdrawal symptoms. This is a very highlighted area when we're checking the brain out and seeing what's being stimulated during withdrawals. And that frontal cortex is actually somewhat damaged in a sense when there's an opioid use disorder after a period of time. And this causes a loss of crucial behavioral guidance, right? You see people that are more impulsive or maybe even inappropriate, and there's just a lack of self-regulation. And so we see people that are actually experiencing or exhibiting basically bad behavior, right? We might see premature or risky behavior. They might be sensation seeking. Maybe there's maybe they're emotionally inappropriate to certain situations. And I'm sure you've seen people that have to deal with this kind of problem where they'll risk going to prison just to use one more time, or they'll risk losing their medical license or pharmacy, or even risk losing their children. You think to yourself, what in the world are they thinking? How is this possible that they would even risk that, knowing what the consequences are? And it's kind of exactly right. They weren't thinking. Something has happened that has made their brain think that that drug is actually the most important thing in their life. And it's not an excuse, but I want you to understand that there's actually a medical problem going on in the brain. And what happens in that reward system is there's that motivation and that drive for survival, right? This is what's the important area of our life, right? There's innate things there. We want food. What happens when you're hungry? Well, your brain says, I'm hungry. Get up and go get food. Or I'm thirsty. Go get up and get a drink. There's that fight or flight where you defend yourself. There's procreation as well. That's an important part of mating and continuing on our species, obviously. And these are innate things in our brain that say, hey, this is important in life. And our brain remembers those and says, hey, that was a good experience, and we should do that again. There's reward and there's pleasure with that. We'll get it right. Okay, well, maybe we won't. Bear with me here. And what happens is, and I like the way that Dr. Volkow at NIDA kind of describes this, is there's a hijacking of the reward pathway. And what happens is basically you have these large dopamine surges that tells the brain that, hey, that dopamine surge that we just experienced is important. We need to remember that. And drugs such as opioids specifically hijack or hack into our limbic system, and they bind directly to the brain receptors that cause release of dopamine. And when that dopamine surges, that's that messenger that our limbic system uses in order to understand what's important in life, what's the most salient and most important thing in life. And it generates a pleasurable reaction in the limbic system. It prioritizes which drives are most essential to life. And once the brain has been hijacked, it'll force the individual to search for drugs with the same strength as if it were food or even greater. And that rational brain is unable to stop it, right? It's almost that hunger or thirst drive, but it's on a much greater level of desire in a sense. And in severe opioid disorder, when there's stress or there's withdrawal or there's craving, it can cause one to pursue that reward, which in this case is the drug, at the cost of everything else in their life, even to the point of death. And you can see here on this little diagram, basically we do have brains that have dopamine surges, right? They're wired that way, so we repeat life-sustaining activities. And then you'll see here, great food. We have a little bump of dopamine in our life because we just had some good food. Okay, that was good. It went above our normal level, and then it goes back to baseline. And then hey, maybe there's some sexual interaction that goes up. There's a boost in the dopamine level, goes back to baseline. But what happens with those drugs of abuse, these highs are so high, these dopamine surges are so high, the brain says, wow, that's important. That's more important than anything else you've actually experienced. And unfortunately, that baseline, actually, they don't go to baseline. Sometimes they go below baseline, and that's when we talk about the withdrawal symptoms, and we'll talk about that in a little bit. And so I like to think of it like a car, right? A car has a braking system, and it's got an acceleration system. You see the top picture up here. This is a normal brain, right? So this is a brain that has control. There's salience, there's drive, and there's memory that kind of go along with this. And if we have a brain, that prefrontal area, it says, hey, listen, we have control, there's executive function, this is where thinking is, and we have a good functioning brain at that point. This is actually the braking system. It says, listen, this is going to prevent you from causing harm to yourself. And your brain will tell you to not cause harm. It's not worth the risk, in a sense. But on the bottom, what happens when the opiates start to hijack that area, you start changing pathways. And the brain's control now, that braking system seems to decrease. And what's really happening is that accelerator is actually increasing more. And there's pleasure seeking overrides reason at this point. It's taking over motivation and drive. And that those former strong connections between judgment and motivation start to shrink. So now you have more accelerator than you do braking system, and you start to realize that that drive and that salient point, which is the drug at all costs, and I remember what that drug felt like, and your brain says you need to do that again, it will drive somebody to use something that they already know is probably bad for them. They're going to do it despite those negative consequences as well. All right. Without treatment, it's difficult to attain abstinence. And really what we're trying to depict here is, this is really kind of the mainstay of medication-assisted treatment. We have interventions like psychosocial therapies and 12-step programs, monitoring. These are great things that we can use in recovery. But oftentimes, if we have a brain that is not stabilized and isn't at a point where it could actually receive that treatment, we don't get as much success from that. And we've noticed that if we start to do interventions such as stabilizing the brain on agonist medications or even antagonist medications, and then utilizing these other interventions, we actually have better outcomes. And so that's how we use those two together. So let's talk about medication-assisted treatment. So what is it? That's the use of medication in combination with other behavioral therapies used in treatment of opioid use disorder, just like what we talked about in that last slide. And it's not unlike the use of medication we use in other behavioral therapies, such as hypertension, diabetes, and asthma. And some people kind of get hung up on the medication-assisted treatment as a phrase, and I think there's kind of two ways to think about that. We don't talk about medication-assisted treatment in diabetes just because they're on insulin. We just call it treatment. But I think there is an aspect that's somewhat important when we talk about addiction medicine. Traditionally, there haven't been a lot of medications used in this. And so oftentimes there ends up being these silos made up of, well, we're of the thought of we're not going to use medications, and then you have the other silos of, well, we are the thought of we are going to use medications. And I think if we say medication-assisted treatment, we're not, getting rid of the other behavioral therapies. We're not discounting them. We're trying to help augment them, and I think that's important to understand. We also, when we talk about medications, we're not just saying, hey, you can pretty much do whatever you want at that point. We don't tell a diabetic, well, hey, guess what? Here's your insulin, and now you can just eat whatever you want. There's both behavioral change and there's medications that can be used as well in that situation. The 3 FDA approved medications are listed here. And really, when you think about medication for treatment of opioid use disorder, there's a few things you want to be able to do, right? That perfect drug would be able to at least get rid of all the signs and symptoms of withdrawal for at least 24 hours. And that dose should also reduce or eliminate drug hunger or craving. It should block the reinforcing effects of illicit opiates. So if the person were to get in a situation where there's opiates that they're going to maybe use again, they don't get the response that they thought they were going to get. And so it's really kind of that negative effect that basically says, well, that was a waste of money. Why am I going to do that again? And then also we don't want a medication that's going to make people sedated all day long as well. So they need to be tolerant to those side effects. And those 3 medications are methadone, buprenorphine, and naltrexone. Now, some of the benefits that we've seen from medication-assisted treatment, and when we use it in combination with counseling, we actually see decreased overdose rates. We see increased patient retention. There's decreased drug use. There's decreased STDs. There's decreased healthcare costs. There's decreased criminal activity. There's decreased criminal justice system costs. And so those are huge wins when you're talking about utilizing medications in other therapies that are already existing. This is a big win here, and that obviously really decreases the cost to the whole expenditure. Like we said before, $750 billion to the U.S. That's pretty impressive. The medications that we're really going to focus on here, really the primary medication I'm going to focus on this lecture is buprenorphine, but we're really going to talk about agonist medications, and they're long-acting opioids that they occupy brain receptors and that are affected by heroin and other opiates. And really what they do is they get on those brain receptors and they normalize brain chemistry. They help relieve physiologic cravings like you just can't even imagine. And so we want to get rid of those cravings. And when you talk to patients that have medications that they can decrease their cravings, that's half the battle. I mean, pretty much all day long, they're thinking, where am I going to get my next drug? There's such a craving for that. And so if we can take that off their plate, we can really help have better interactions and intervene in their lives better. Obviously, the opiates, these long-acting opiates will actually prevent withdrawal. They normalize body function as opposed to these ups and downs. They actually get stabilized, and I'll show you a slide in the next couple of slides how that works exactly. We need to remember that dosing is really an individualized medical decision, and that's important to understand. We don't sit there and say, well, you're at this milligram strength, and this other person's at this one, therefore you're doing better than them. It doesn't work that way. Everybody is a little bit different as well. We also want medications that don't impair functioning. So if somebody's on buprenorphine or methadone, we want to be able to get them to a point where they are functional. They can have a job. They can take care of their family or go to school. And really, we want those medications of both of them really in the long term. We haven't seen negative side effects on intelligence or mental capability or physical functioning or employability. In reality, we've actually seen an increase in employability and physical functioning, and to be able to do things that they've wanted to do that they haven't been able to do in their life. Initiating treatment in the ED, the medication that we're really focused on in that situation is buprenorphine. Buprenorphine is what we call a partial agonist. It works on the mu opioid receptor. Heroin goes to the mu opioid receptor. Methadone as well. Methadone is what we call a full agonist. But buprenorphine is a partial agonist. And there's a bit of a safety factor there. So it has a high affinity and a low intrinsic activity. So what that means exactly is it wants that mu receptor more than anything else around. If there's heroin around, it's going to knock the heroin off and it's going to grab that receptor. If it's attached to the receptor already and there's heroin that kind of comes in the system, the heroin can't get on that receptor because the buprenorphine likes that receptor more than the heroin. That's what we talk about, a high affinity. And when we say low intrinsic value, really that is a situation because of that partial agonist effect, you have less euphoria and there's a lower diversion potential. People just aren't getting high off taking buprenorphine. They're just getting normal. And so that's a good type of safety mechanism as well. And so it's very, very difficult to overdose on buprenorphine. And really all the times that people have had buprenorphine in the system and overdoses, it's almost always been with polypharmacy, such as benzodiazepines and alcohol as well. This slide is really important to understand, and I really like this one. As somebody, if you look on the left side and you say, this is the first time somebody started using that, acute use, and you say, okay, somebody gets an opiate in their system, they're living at that normal range, that blue area, and they have an opiate in their system, they'll have that huge spike of dopamine, they get that rush, they get that euphoria, the brain says, wow, we have to remember that. That was pretty awesome. And they're like, okay, let's do it again. And it happens over and over and over again. And you start to see that graph starts to maybe not get so far into the euphoria. They're not able to get that high that they used to have before. And at some point, this is where it kind of changes into an addiction because now they get to this level where, wow, I'm feeling sick if I'm not taking this drug anymore. And now when I take that drug, that's the only thing I can actually take to get me feeling normal again. And if I don't take it, I'm so sick I can't even function anymore. And that's where that physical dependence and tolerance has occurred. And when we bring in medication-assisted therapy, our whole goal is, basically a long-acting medication, is we'll bring them back up to that normal state, not in the euphoric state, not in the sedated state, but in that normal state over a long period of time. And so then they start to be able to gain function again. They have enough energy to get up and go to work, and they're not having cravings, and they're not having withdrawals. They just feel normal. And for all of you that have worked with this patient population, you know exactly what I'm talking about. It is just almost life-changing for them because they forgot what normal felt like. So that's very important to see that. Let's focus a little bit on the ER. So why do we focus on the ER? Well, guess what? That's where all the patients are, right? I mean, there's a lot of patients in the ER that come there for opioid use disorder, whether it was an accident or maybe an IV drug infection, or maybe they had an overdose. Guess what? We're open 24 hours a day, 7 days a week. Our doors are always open. And so we want to treat patients for opioid overdose. That's where we do it, obviously. And we also want to treat them for withdrawal. And that's a great place that we can actually intervene with these patients. some of the things that we want to look at, we want to be able to screen and identify patients with opioid use disorder, and I think that's important to understand how to diagnose that. We want to be able to provide treatment, so initiating MAT, such as buprenorphine, obviously educate for overdose, and giving them the education to have overdose prevention, and then ultimately naloxone distribution, right? Naloxone is the antagonist of all antagonists for opiates. If I give you naloxone, you have an opiate in your system. The opiate gets knocked off the receptor, the naloxone gets on there. The good thing about that, if you have stopped breathing because of the opiates, and I give you this medication, I can get you breathing again. So it's a life-saving medication. So we want to be able to get that in the hands of anybody that's at risk with opioid use disorder. And we want to be able to link patient with ongoing treatment. This isn't just a one-time, hey, you went to the ER, we took care of you today, and we're not going to continue any treatment after that. And I think it's important to make sure that we create those relationships on the outpatient standpoint, that patients can continue to get that treatment as well. In 2015, Dr. D'Onofrio up in Massachusetts really was quite a pioneer in talking about, let's start doing this in the ER. And so, they realized, listen, addiction's a chronic relapsing disease. It's strongly stigmatized, obviously. Basically, when somebody that has an opioid use disorder comes to your ER, it's not a fun experience usually. It can be very difficult. Sometimes they're going to die on you. Sometimes you just treated them like 8 hours ago and sent them home and they come back with another overdose. It can be very, very frustrating. And I think what we need to understand when we look at that disease process of the brain, that this just isn't a moral failing, right? There's something actually going on in these folks' brains that might be something wrong. And can we do something to help them? And so people that present to the ED for other chronic diseases like diabetes and asthma, we stabilize them with medications and we hand them off to outpatient providers, right? We take care of that DKA patient that's having a crisis or the asthmatic that's in status asthmaticus. And we don't just say, okay, you're fixed, go away, don't follow up with them. We try to get them hooked up with other people as well on the outside to continue that treatment. And in her study, she had 3 kind of study groups. Basically, we're just going to do traditional referral. All right, you have an opioid use disorder. Why don't you go follow up with this outpatient clinic? Okay, here's a list of places you can go. The second group was basically, hey, let's talk about the fact that you have an unhealthy relationship with your opiate. We actually think you might have an opioid use disorder. Let's talk about some things that if you're ready for change, and we're going to give you some intervention here right in the ER and talk about risk, and then we'll also refer you as well. And then the third group was something unique where they say, let's just start treatment. Let's just start treatment with buprenorphine in the ER and then have them follow up with as a referral and follow up with an outpatient clinic. And they said, okay, what are our outcomes? Well, if they're still engaged in therapy at 30 days, let's make that our primary outcome and see where we're at. So what did she find? She found that, wow, it was almost twice as good for patients staying in treatment when they were given buprenorphine in the ER. That isn't going back to the ER for more. This is staying in an outpatient treatment. 30 days later, clearly starting the buprenorphine in the ER had a major factor in their retention in treatment compared to the just referral or even brief intervention in the ER as well. And how about days of use? So for the folks that, you don't always get perfection, but one of the things you're also trying to do is harm reduction, right? So from a harm reduction standpoint, for those folks that had brief intervention or referral, the number of times they used a week was somewhere between 2.3 and 2.4. But for those folks that were actually started on buprenorphine, it was less than one use per week, which is pretty dramatic actually. So obviously there's some harm reduction that can be life-saving in many situations as well. It's not just simply replacing one drug for another. Remember what we talked about. Buprenorphine treatment decreases withdrawal and craving. And they get that buprenorphine, and what happens when it's in their system? They're less likely to overdose. They're less likely to die. They're less likely to use illicit opiates or spread hepatitis or HIV. They have fewer injection drug use complications, and they're not involved in the criminal justice system as much. So this isn't just replacing one drug for another. This is treatment. My computer gets very excited about going fast. All right, so here's a study, and this is replicated in Baltimore. I believe this is the French study. And basically, what it showed in France as well as in the U.S. is as you introduce medication-assisted treatment, you decrease the heroin deaths that occur from that. As you can see, the red line here represents the heroin deaths, and the buprenorphine and methadone, as they start to come into the population and start to go up, you start to see that the heroin deaths start to go down as well. So that's a direct correlation from that. So do the ER doctors all need an X waiver? And really the answer is no. Is it ideal? It'd be great if everybody had an X waiver. An X waiver, basically, you have to take a class as a physician where you, it's about an 8-hour class. It's free, and I'll talk about that in a little bit. But basically, it's a free class, and you get an X in front of your DEA number. So instead of my first 2 letters are BS, believe it or not, BS, okay? But so I was kind of excited to get a waiver because I got to change it to an XS instead of a BS. So that was a win-win for me. But it's fairly simple to do, but it's not necessary in an ER, and I explain that. So is that legal to actually give buprenorphine when you don't have an X waiver? Well, it is in a hospital setting. Now, there's something called a 3-day rule. Basically, it's okay to administer daily for 72 hours. And what that means exactly, you can't prescribe it. I can't give a patient a prescription of buprenorphine to go home unless I have an X waiver. But if you come to my ER, I can administer the buprenorphine to you at your visit there. So if you're in the ER, I can give you buprenorphine as a patient. But then I have to discharge you, and I can't give you a prescription. There's something called the 72-hour rule, and I believe it was put in place because people said, well, listen, we want you to get them to outpatient therapy. And the question probably arose, well, what if it's Friday? Nobody's open on Saturday and Sunday. So that 72-hour rule kind of covers that, right? Well, okay, they can come in Friday and get their first dose. They can come in Saturday, get their second dose. They can come in Sunday and get that third dose, but that's it. They need to follow up with outpatient therapy at that point. If you want more information about that, I put a website on there. You're going to get these slides afterwards, so we'll be able to access that later. Initiating that treatment, ED docs can administer the buprenorphine in the ED for opioid withdrawal. And really, within about 30 to 45 minutes, the patients will feel much more comfortable. It can be very dramatic. If any of y'all out there are docs that have been able to do it before, you can attest to what I'm talking about. It can be very dramatic how much better they feel. Doctors and PAs and nurse practitioners who complete their DATA 2000 waiver training can prescribe buprenorphine with referral to ongoing treatment. That 72-hour rule I'd mentioned before, it's a CFR Part 1306. They basically say they can show up to the ER each day, get another dose, but you can't write that prescription unless you have that DATA 2000 waiver. But oftentimes, really, what we're trying to do is get them that first dose, let them understand that we're here to help them, and then they will continue on with their care as an outpatient. What's our primary goal? A lot of people say our primary goal is to stop them from using drugs, and in reality, our primary goal is just to keep them alive. That's the most important thing. If you don't have a live patient, then you don't have a patient to treat, and so that's very important. It's not our ultimate goal. Our ultimate goal really is to attain long-term recovery, maintained with or without medication, to provide protection from an overdose and death while improving physical, emotional, and psychological health. We want to keep that person alive. We want to keep them from having those moments where they have relapse. And if they were to have relapse, we want to provide that protection as well. We want to see improvement in their overall life. And that's what they want as well. And I think this might be a good place. Actually, let me finish this slide, and we're going to take a little 5-minute break. So in the emergency department, we have patients, they're going to present with signs and symptoms of drug use. And so we're trying to identify it. It's pretty simple sometimes, right? You just had a major car accident because you're under the influence. There might be a substance problem there. You have an IV injection site that's infected. That's probably an addiction issue. But really, we see a lot of folks with opioid withdrawal, with overdose, infection, or people just that are seeking treatment for opioid use disorder. It's important to get a urine drug screen, not just because we're trying to catch somebody or anything like that. We're basically saying, listen, we want to make sure that we can safely give you a medication. First of all, we want to make sure that you actually have an opioid use disorder, because otherwise we shouldn't treat you with buprenorphine. That would be inappropriate and somewhat actually dangerous. And we also want to make sure they're not on long-acting medications such as methadone. Methadone is a long-acting medication. So if it's a long-acting, what we call, and I should say, a full agonist medication, because, and I'll explain that a little bit later, but we can actually displace that full agonist with a partial agonist and create something called a precipitated withdrawal where the patient feels quite sick. We want to make the diagnosis of opioid use disorder. The patient is screened for opioid use disorder. Usually we'll use the DSM-5, and there's a withdrawal severity. There's something also called the RODS. We can use RODS, and we use a COWS scale to kind of tell how bad is their withdrawal right now, and is it safe to start treatment in the ER. So I think this is a good stopping point to have a little 5-minute break.
Let's take a 5-minute break at this time. Hello, everyone. Welcome back to today's webinar. Dr. Stavros, if you're ready, I'll turn the presentation back over to you.
I'm ready to go. All right, that was a good break. All my boys got to run around the house and scream for a little bit, so they were pretty happy about that. Okay, so now we're back on quiet mode for them. Let's talk about, I'm going real fast here, so let's see. We briefly talked about that emergency department evaluation, and really let's continue on. We'd like to do something called a brief negotiation interview, really kind of seeing what that readiness is for change for that patient. Medication treatment is initiated in the ED if the patient's willing. And then also we'd like to refer them to treatment, obviously, or maybe even a warm handoff where we're using peer support. What's peer support? They'll evaluate that patient in the ED and arrange outpatient follow-up. So somebody will actually come by the bedside, and I'll talk about that a little bit more. And we obviously offer take-home naloxone kits to patients and families. Obviously naloxone is for overdose. What is the overdose triad? Patients that have pinpoint pupils, they're unconscious, they have respiratory depression, or they're not breathing at all. What do we give them? We give them naloxone. The brand name is called Narcan, but naloxone also comes out generic. Apparently, they just recently came out with the generic nasal spray, so that'll help decrease some of the costs as well. Opioid use disorder, it is in the DSM-5, in the psychiatric guideline. Basically talks about mental disorders and really what is the diagnostic criteria behind that. We need a minimum of 2 to 3 criteria for mild substance use, 4 to 5 criteria for moderate, and 6 to 7 criteria for severe. And when you talk about all 11 of them, we'll go through 11 of them pretty quickly. 10 and 11 really just can't stand alone without any of the other 1 through 9, and I'll explain that in just a little bit. So what are the criteria? You ask the patient, have you been using larger amounts, or you're using it longer than you're supposed to? Are you wanting to cut down but you just can't quit down? Are you spending a lot of time obtaining the opioid, or maybe you're under the influence of it as well, or maybe even recovering from it, hungover in a sense? Do you have a strong desire to use? Are you having that craving that can be overwhelming? Is it affecting your work? Are you unable to carry out those obligations at work or school or even at home because of that drug? Do you continue to use even though you know it's kind of affecting your relationships or made your relationships worse because of that drug? Stopping or reducing important social, occupational, or recreational activities? Are you just not going out and doing the things you used to do before or having fun? Are there physical situations that are hazardous to you? Are you getting in car accidents? Are you having more injuries because of it? Is there consistent use of opiates despite the fact that you know that it's physically, affecting your life and you're having physical changes? When we talk about 10 and 11, tolerance and withdrawal, we can create tolerance and withdrawal with anybody that's on chronic opiates. Opiates basically will create tolerance over time. And if I take that opiate away from you abruptly, that will cause withdrawal. Does that mean you have an addiction? No, it's the other behavioral aspects that we just talked about, 1 through 9, that makes it an opioid use disorder. So the 10 and 11 don't stand alone unless they have at least, or moderate, 2 of the other criteria as well. Rods, we're going to talk about rods and cows. I just gave you a brief little thing to look at. It takes about 2 minutes. It's a rapid assessment, basically, to check for dependence and possible opioid dependence at that point. You can look up this website if you want to learn more about that. Really, the mainstay that we use withdrawal screening is the COWS scale, and I'll show you a brief picture of the COWS. If you have a score that's mild, we're really not going to start medication. You have to at least be in moderate opioid withdrawal according to this scale to initiate medication, and obviously severe as well. You can initiate medication, but you might even need more than 1 dose of medication because it's severe. And then obviously post-overdose resuscitation patients, somebody that just had a code, they stopped breathing, we brought them back with Narcan. Those would be patients that obviously will pass the withdrawal screening. Here's a picture of the COWS. I won't go into depth of it, but basically you can just score this. There's objective and subjective. Is there, what their pulse rate is there sweating, what their pupil size is, are they having aches, are they having goosebumps, are they yawning, Are they having tremor? These are the things you just go through. On MD Calc, which is an app on your phone, you can just download that and sit there in front of the patient, just ask question by question by question. At the end, it'll add up the score for you, and it gives you an idea what that COWS score is. And really, we want that COWS score to understand if we should initiate treatment in the ER. That brief, just a quick summary. We do a brief negotiated interview. We start buprenorphine, sublingual in the ER. The COWS needs to be over 8, and I'm going to talk in a little more detail about that in a moment. That helps those severe withdrawals. We have overdose education kits, and then we also do that referral or that warm handoff with peer support. And what do I mean by brief negotiation interview? So really, it's that chance to raise the subject with the patient. And really, I think one of the interesting things that happened July 1st of last year is that House bill that basically said we're going to limit the amount of medications I can write for a prescription for opiates, which really, it was kind of frustrating a little bit. I have to check the PDMP every time. I've got to make sure that I'm limiting my prescriptions. But at the same time, it's kind of offered me that opportunity to talk to patients about the fact that, hey, why did you run out of your medications you're here at the ER? You know, we start to maybe approach that patient a little bit differently. Let's talk about it not from a judgment standpoint, but let's talk about, is there a problem going on? And I think that's very important, at least from the ER, not to approach a patient with judgment, and really just being there as a provider that's going to offer care. And traditionally, I'll be honest with you, I had to learn this in my career. Traditionally, we really didn't have a lot of tools. I can bring you back to life with naloxone, and I can tell you stop using drugs or you're going to die, but that's it. I mean, I really didn't have a lot of tools. And so being able to actually do something in the ER and approach that patient with options and maybe even a tool that I can use to help them is a huge win for me as a provider. It's really changed the way that I can actually treat this population. So you raise that subject of drug use, you come to the patient without a judgmental attitude, and you establish that rapport, and then you can start talking about how comfortable they are. We talk about pain. I may not be able to get rid of all your pain. Let's talk about pain scales. Let's talk about your relationship with your pain medication as well. We provide feedback. You know, you talk about the patient's substance use and patterns, and maybe that PDMP, that website we look for other prescriptions, is a time where we talk about, hey, do you realize you filled these scripts at these several different places? I'm not here to just bust you. I'm here to actually talk to you about the fact that you might actually have an unhealthy relationship with your medications. And we bring those connections. We talk to them and help them connect that, you know, the substance use has actually led to this negative consequence, right? You've had impaired judgments leading to this injury that you may have had, or maybe you have a STD, or maybe you have an infected injection site from sharing needles. And so these are those conversations we can start to have with the patients, not to judge them, but to help understand that, hey, we understand this is a disease process. We want to help you actually get better. Excuse me. We want to make that connection between the substance use and that ED visit as well. And then I think it's important to ask them, how ready are you for change? You're not going to get every single person that comes in and wants a change. I remember a day I had 2 overdoses. I gave naloxone to 2 of these folks, and I'm like, listen, you just died. You died right in front of me. We brought you back to life here with naloxone. This is obviously a bad thing. Death isn't good to keep alive, right? So that's a bad thing. We want to make sure that you stay alive. Are you ready to change? Obviously, this affected your life. And they said no. And I was dumbfounded. Like, how did I mention you died? You know, so, but we have to understand that not everybody is at that point of readiness to change. And we need to kind of assess where they're at. So you ask, hey, on a scale of 1 to 10, how ready are you to start cutting back or maybe enroll in a program? And maybe you're going to get somebody that says they're on a high level, but let's say they say, I don't know, I'm not really a 5. Okay, well, why didn't you pick a lower number? Why didn't you pick 3? You know, because there's clearly some motivation here, some readiness for you to change. And then you have that discussion, why not today? We can do something to actually help you. We talked about the medications we use. Buprenorphine is a partial agonist. This is a diagram here. The red dots really show that full agonist, that methadone. Really all the receptors are kind of locked and loaded in a sense, are on full blast. And then when I bring in a partial agonist like buprenorphine, I knock off those full agonist medications and I decrease that opiate effect in their life so I can actually precipitate a withdrawal. There's huge benefits to buprenorphine. Like we said, it has a high affinity, it's less abuse prone, but you got to be careful if there's other opiates in that person's system and they're not having withdrawal symptoms, right? Because if they don't have the opiate in the system, they go through withdrawals. If they don't have the withdrawal symptoms, that might mean there's quite a bit of opiate in their system. And if I give them buprenorphine and I change that level dramatically quickly, I will create a precipitated withdrawal. Doctors D'Onofrio and Doctors Hawk in Massachusetts came up with these unbelievable diagrams, and so kudos to them. But I want to just briefly go through this, and I won't spend a lot of time here, but basically this is a great diagram and a schematic about how to initiate buprenorphine in the ER. We talk about the fact that we want to see that they're in withdrawals. We make that diagnosis. Are you in moderate to severe opioid use disorder? Yes. Okay. Are you in withdrawals? Well, if you have a level of 0 to 7, you're not ready for medication. You might have another opiate on board that if I give you this buprenorphine right now, you're going to have a precipitated withdrawal. And if they do, they're not going to like it. They're going to feel pretty sick from that. So that's a situation where if you have a waivered physician, they might want to prescribe buprenorphine. If you don't, then you need to refer those folks on to ongoing treatment. Or if you have that ability to observe them for a certain amount of time, which is very difficult nowadays with the throughput in ERs, then you can actually do some buprenorphine a little bit later and then refer them later. But what we're looking for is at least a CAS scale of 8 or higher. And we explain to the patient, listen, we really, because some of that's subjective findings, we want to make sure that you're in pretty severe withdrawal before we give you this medication because we don't want to make it worse. And we start with a dose somewhere between 4 and 8 milligrams. It's sublingual. And when you give this medication sublingual, it's absorbed under the tongue. If they swallow it, it's destroyed by the stomach. And I think it's important to understand that this medication comes as a brand name. There's 3 brand names that I know of, Suboxone, Bunavail, and Subzol. All 3 of those combine the medication naloxone in there. And some people think when we talked about that precipitated withdrawal where we give somebody buprenorphine and all say, oh, they had a withdrawal, it must have been from that naloxone that's in it. It's actually not from the naloxone. It's the fact that buprenorphine is a partial agonist that causes it. The naloxone is only there to deter IV use. So if that person were to melt that down and put it in a needle and shoot it up, well, then the naloxone becomes active and they have a withdrawal from that. Otherwise, the naloxone it's just almost not absorbed at all under the tongue. And so that's not what they're having a withdrawal from when they have that precipitated withdrawal. It's actually the fact that buprenorphine is a partial agonist compared to the other full agonists in their system. So after that dose, we give them around 4 to 8 milligrams. You watch them for about, like we said before, 30 to 60 minutes really, making sure they're not having an adverse reaction. And then if that initial dose seemed to work well, we can actually repeat that dose. You can observe them for a while. If you have a waivered physician, you can write a prescription for them. If not, you can refer them on to treatment as well. And as a matter of fact, if it's on a weekend, again, they can come back the next day for another visit, get another dose, and then they can come back one more time after that for that 3rd dose. That's that 72-hour rule we talked about. And then they can get handed off to an outpatient treatment. Warm handoffs work the best when you have those relationships that are already in place with the ER as well. And we'll talk about that as well as peer support. If you have, you're going to have those patients on that left side of the arm. Let's say you had a patient that wasn't ready basically to start or have initiated buprenorphine in the ER. Here's a nice schematic about how you do home induction. You can actually, and we'll do this in like an office-based opioid treatment programs all the time. And so basically from an ER, you're going to talk to the patient about, listen, you want to be in pretty bad withdrawals before you take this first dose. So if you have a waivered physician, they can write a small prescription for buprenorphine and say, okay, listen, I want you to take 4 milligrams when you're starting to feel bad, really bad withdrawals. And then if you still feel sick after about 45 minutes to an hour, take the other 4 milligrams. And just wait about 6 hours or so. And then if you're still feeling uncomfortable, take another dose at 4 milligrams. And let's just stop. Your first day is somewhere between 4 and 12 milligrams, and it depends on how bad you feel. Are you still in withdrawals? Are they feeling sick? And if so, they continue to increase that medication. If not, that's their daily dose. On day 2, they can even go up to 16 if they wanted to. But if they said, hey, listen, I felt better at 8 milligrams, they continue 8 milligrams at that point, and then they follow up with their outpatient provider. Harm reduction strategies, very important to talk about. We want to make sure that we get naloxone in the hands of these patients or at least their families and give that education. We talk to them about, hey, listen, if you're not ready for change, just make sure you're never alone when you're using. I mean, let's say this person came in as an overdose. Obviously, they're at risk for overdosing again. We want to make sure that they're not going to be using alone. Talk about not combining opiates with other things like alcohol or benzos, any other sedative, because that can decrease their respiratory drive and they can die from that. Divert low-level crimes from the criminal justice system. Maybe we can talk to our local law enforcement about getting them treatment as opposed to jailing everybody. And that's kind of a bigger discussion than we can do here. Then obviously talk to them about not sharing needles, and equipment. Obviously you got to use clean equipment. They're going to talk about safe injection sites possibly, or even needle exchange programs. That's well beyond this discussion, and that's from a different standpoint. But there's some aspects that might be beneficial as well. And really, we want to be able to prescribe or distribute naloxone. Naloxone comes in several different forms, but really the one that we're going to give the most is naloxone nasal spray. That's FDA approved back in 2015. There's 4 milligrams in just a 0.1 milliliters of it. It's a single dose in one nostril. It's very, very rapid delivery, and you can repeat it actually in about 2 or 3 minutes if needed. The price is pretty low. A 2-pack comes under $100. It can be free or even insurance covered in many states. Here's a great resource, iSave Florida. So naloxone locator, and I think my next line will actually tell you the point of contact really to get a hold of is Amanda Mueller. Amanda is absolutely amazing. If you get a chance to talk to her, so proactive and so passionate about this problem. But if you can contact Amanda, really in an ER setting, we're really trying to get these patients the naloxone in their hands before they're even leaving the ER. The Surgeon General has already signed a standing order. Anybody can go to the pharmacy and get Narcan, or not Narcan, but naloxone, and even without a prescription, because it's a standing order. But of course, there may be a cost to that. But if we can actually give a patient that medication before they leave, that's a huge win. We need to know our local resources, and I think that's very important. Where are your opioid treatment programs? Where are the primary care practices that are actually doing Suboxone therapy, residential clinics? Maybe you have an FQHC that will take that warm hand off. If you establish those relationships beforehand and you get those patients to say, listen, I know exactly where you need to go. I'm going to go ahead and give you the referral. Maybe you have like a standing appointment the next day at the local OTP. It's like, oh yeah, we'll take any of your patients anytime. And by the way, they're open not 24/7. They're open almost every single day, maybe not on a Sunday in some places, but they're constantly available. And we want to make sure that there's not waiting lists at those places. But you want to know what your resources are outside of your ER as well. Obviously, we need to think about insurance and funding. There's so many grants for this right now, and a lot of funding that are coming from the state as well. Find out who those champions are in the ER. Maybe some of them want to be waivered. Maybe all of them want to be waivered at some point. But if you can find just a couple of people, 1 or 2 people that say, hey, I really want to make a difference, I want to make a change, then that's really where you start a program and you move in that direction. They can really create quite a bit of influence. And I'll tell you, it will spread like wildfire. Get your social work involved, and peer support is very important. So what is peer support? Peer support is literally a person, and they don't have to have a history of opioid use disorder, but I'd say the vast majority have had a history of opioid use disorder that's in recovery, and they physically come to the ED and they start talking with the patient, right? It's like, hey, I have a friend here of yours. Here's a new friend. Basically, they've been in your shoes, and they can talk to this person on a different level. Like, we all like to talk to kind of our same a little bit, right? So doctors, they like to hear from other doctors talking about things, and social workers from other social workers, because we all kind of relate. You have somebody that's dealing with opioid use disorder, and you have somebody that's in recovery from that same problem. They listen. They have a chance to listen there. And that person can actually help educate that patient on those treatment options and harm reduction, and let them understand what medication-assisted treatment is. Maybe that's a chance where they talk to them about how to use naloxone, not using alone, those harm reduction strategies that we talked about. And they can actually help facilitate ongoing treatment after leaving the ER. Or, hey, I got an appointment tomorrow. I'll actually come pick you up, and I'll take you to the appointment tomorrow. So there's a lot of things that they can do, and it's really, the studies have shown that this has been very, very impactful. And there's really a growing body of evidence suggesting that peer support workers, they effectively connect with individuals suffering from OUD, And proper treatment and recovery intervention is often greater than what the primary care or clinical behavioral staff can give. So it's been a huge win if you can actually implement that as well. It's important to understand that you need to anticipate resistance, right? Around and not just resistance from the patient, but resistance from your ER staff. I mean, this is like, whoa, this is a lot of work. I don't know if I want to do this. And so we really need to find out what kind of motivates the different key stakeholders, right? You need to let them understand, like, we are going to have reduced repeated ED visits or maybe even reduced psych holds because we're actually treating these patients and getting them into recovery. There's an aspect of staff safety, or the length of stay can actually be decreased in this situation, or patient satisfaction. We change that culture by engaging all the stakeholders, from administration all the way down to housekeeping, helping them understand that we're here to try to get these folks, number one, alive, but get them the treatment they need so they don't have to keep cycling through the ER as well. And it takes time for that change. You don't want to wait for that perfect protocol or system. You just got to start somewhere, just even if it's education. Let's talk about harm reduction strategies and start there. Let's do naloxone distribution and start there. And so you can just start little by little if needed, but if you can bring in that medication-assisted treatment, you really make a huge impact in these folks' lives, and it saves lives, actually. And you make it as simple as possible, right? Maybe you make protocols as well. We're talking about improving patient care. So let's kind of, to close this out, I'm going to go through some concerns and realities and solutions regarding opioid use disorder and buprenorphine treatment in the ED. So some concerns get brought up, and they're like, okay, wait, addiction's a moral failing. People keep coming back to the ED time and time again. Well, reality, addiction is a chronic and relapsing disease. We talked about that. And it can be effectively treated with opioid agonist therapies. ER doctors, they're kind of skewed a little bit from the sampling that we get of patients that are not in treatment, right? Because there's a lot of people out there in treatment that are doing very well. I get to hear a lot about the ones that are not doing well. But we don't get to see all the ones that are actually doing well because they don't come to the ER. And I think that's important to understand. Woo, busting through it again. Really, we need to provide specific feedback to the ED providers on success stories, right? Share those stories of that person that came in and had an overdose. And that one, I told you before about that one that said, listen, I'm not ready for change. Okay, well, let's talk about harm reduction. And they got discharged. I gave them referral. But I've also had that one that came in and said, yes, I am ready for change. And you initiate buprenorphine, and then they come back a month later and they say, thank you. I'm actually in treatment now. They didn't come back to the ER because they're an overdose. They came back to thank you because actually their life is better. We get to hear these success stories, but we need to share that with our staff, let them understand that it actually does make a difference. Providing buprenorphine, what's another concern? Providing buprenorphine to patients will lead to diversion. Well, in reality, there's less diversion of buprenorphine than other opiates. Buprenorphine is bought off the street typically is actually used just to stave off withdrawal symptoms. Every buprenorphine pill is one less opportunity for overdose, right? So if somebody actually did end up diverting it, and most people that have been on opiates before, you say, have you ever tried buprenorphine? Well, only off the streets. So they've had some experience. There is buprenorphine on the streets, and really what it's been almost safer, obviously, than having to inject, right? So less chance of having an overdose death in that situation as well. But maybe you just offer limited supplies, maybe 2 to 7 days worth of treatment if you have an ex-waivered physician until that appointment can be arranged. But, obviously greasing those skids to get that patient into treatment because you've already established those relationships with your outside providers is very, very important as well. What's another concern? Initiating buprenorphine treatment is complicated. The ED is already crowded and chaotic. Well, it really isn't that complicated. You just need to learn how to do it, and then once you get a feel for how to do it and do it safely, it can be pretty seamless. It can be safer. It's more predictable than other medications that we use in ED practice. My gosh, we use all sorts of other medications that are much more complicated than buprenorphine. And they can be, accomplished in less time than really an urgent care visit. What do? We integrate protocols electronically. Your EMR, we can create protocols that make it simpler for providers to help them all the way from triage to discharge and engage them to help facilitate and simplify those streamlined processes. Just identify those champions that will kind of help move that along. But you can create processes that can be very simple as well. And then obviously, if you have peer support, they can really take a lot of that workload off your staff as well. How about this one? There's a lack of referral sites for patients who have initiated buprenorphine treatment. Well, there's most communities probably have treatment resources that we're probably not even aware of. The FQHCs or the OTPs, outpatient treatment programs, or the opiate treatment programs, even office-based opioid treatment programs as well. We partner and develop those relationships like we talked about. We go to those community resources. There is a lot of money that is being resourced towards this. And for somebody in your area, you just need to find out who your provider is in that area, because they're actually being funded to start buprenorphine and continue that buprenorphine treatment as well. Maybe we need to hire ED staff members, such as a health promotion advocate, which is helpful and cost effective. So that maybe that's that time where you have that discussion and say, hey, listen, we're making such an impact. We probably actually need an FTE for this, or at least a part of an FTE. And maybe when you start realizing, your administration starts to realize how impactful it is, you can get a lot of buy-in. Here's a huge one that I get to hear all the time. It's like, oh, great, we're going to start buprenorphine now. Everybody in the world is going to come here for their treatment. Well, you know what? In reality, they're already there in your ER for treatment or for something, right? So for the sites that actually did ED-initiated buprenorphine, they don't report an uptake of patients seeking treatment, actually. It's not actually true. They've actually done studies to see if that happens. So if you initiate those treatment protocols at triage to promote that rapid assessment and treatment and referral, you actually get somebody that might actually stay in treatment and not coming back to the ER so much. And so that's very important. We have an opportunity, like I said before, an opportunity to make a change in this person's life. We're not going to help everybody, but we're going to help that one person that's ready for change, hopefully. And we need to have the tools available to actually make that difference in their life. Many patients don't want treatment, just kind of what I was just talking about. You know what? Many of them don't. They're not ready for it. They're contemplating. Even after an overdose, they're not ready for treatment, or even after a brief psychosocial intervention. But that discussion sometimes is the key. That person could remember, like, wow, that ED provider didn't actually talk to me in a judgmental aspect. They kind of seemed like they cared, which could be very different. This is a group of people that don't trust the healthcare system, because let me tell you, they've probably been treated pretty poorly in the past. So just coming to a patient and changing their attitude about what the healthcare system can do for them is a huge one. Even if they're not ready at that time, they might be ready the next time. And it's often a missed opportunity to engage those patients who might be contemplating a positive change. But we don't want to miss that chance. At the least, we can offer some harm reduction strategies, such as overdose prevention, and even giving them naloxone to help save their lives. That helps help us establish that rapport and improve those outcomes as well. Obtaining a waiver to prescribe buprenorphine is too burdensome. Well, it's actually not that hard. I could probably do it today. Really, in reality, it's an 8-hour course. It probably takes about 4.5 hours online. The training required, it can be done in a half day. It's online. It can be free. So it's pretty simple in regards to that. You need to identify those champions that are willing to do that as well. And I think that will make a huge change. If you want more information, SAMHSA, as well as ASAM, American Society of Addiction Medicine, they have websites that can help get you the training if you're interested in that as well. Yeah, I just want to, with a final part of this presentation, I want to give you an example. This just recently came out, recently, April 17th of 2019. And you think to yourself, well, this might be great to have in these big meccas like, Gail D'Onofrio's up there in Massachusetts, and there's just a huge amount of stuff going on and lots of progress. And here's a little place in Maine, New Brunswick. They have 30,000 annual visits. Can they make a difference? And so a mid-level, not even a doctor, a mid-level said, I want to make a difference with OUD. And that person decided, I'm just going to go ahead and start creating relationships with the local, opioid use disorder clinics in my area and find out who they are, because at least I can make a referral. But, I really want to start buprenorphine. So this person goes and gets their waiver, but not everybody really wanted to get their waiver, but that's okay. They started with not even having to do a waiver. And they basically said, listen, we want to start buprenorphine induction in the ED. Well, people were a little reticent, a little worried. And so they said, let's do an in-service. Let's talk about it. We don't even need to get an X waiver. You're going to administer it. You're going to start treatment here. And then guess what? We have relationships with some of our outpatient providers that I've actually gone and tried to make a relationship with. They want to see these patients. What happened? After 14 months, pretty slow going. Only 35 patients in 14 months. That doesn't sound like a lot. But 94% made it to the first aftercare visit. And 70% were still in treatment at 30 days. That's huge for those 35 patients, right? That's a big deal. And you think, well, is that big of a win? Well, listen, it's starting in the right direction. There's a great program that they've actually changed a significant amount of people's lives just by starting this induction and in the ER and then getting them to referral. And I love this quote. These are low, this is from the person that wrote the article. These are low volume but high risk and high impact situations. Compare this to stroke, okay? In our emergency department last year, we gave TPA. This is that drug that breaks up blood clots, right? 15 times, okay? And like many of you who are medical directors in the ER, I've spent an amazing amount of time working on systems of care for our stroke patients with perhaps much more doubtful impact than recovery can have on a life. And for anybody that's on here that's a medical director or works in an ER, you know exactly what I'm talking about. We talk about stroke intervention all day, all week. It's constant. But we're talking about a pretty low amount of patients. The opioid use disorder, we see a lot more patients like that have an opioid use problem. And so we can actually probably have more of an impact in that patient population than even the stroke patient population. What are some of the benefits and developments? So there's clear benefits. Lives are saved. There's less recidivism in the ED in this study. It's rewarding for the ED physicians because they actually get to see change in these patients. A couple other quotes from this article. While patients with opioid use disorder can sometimes be difficult, I would argue that much of the stigma and bias surrounding these patients come from our frustration with the situation. It's important not just to give a phone number, but to start that life-saving treatment in the ED, and they are actually able to witness those changes, and I think that was important. It was important to need those partnerships with the local recovery centers, standard protocols for screening and dosing, and referral should be in place before you even start that process because you need to have somewhere for these folks to go to so they can continue that treatment. So just a brief summary. We're obviously in the midst of an opioid crisis like we discussed. It's over 70,000 deaths a year. We understand that this is a chronic disease of the brain. It's not just a behavioral disorder. Medication-assisted treatment, specifically buprenorphine in the ER, improves many outcome measures. And there are interventions that we can do in the ER, not just buprenorphine, but some of the other interventions and getting peer support for patients with opioid use disorder. So that is the conclusion of the webinar, and I will await any possible questions. So thank you very much. I appreciate your time.
Dr. Stavros, most OUD patients are heavy IV users, which it has been shown that buprenorphine is much less effective than methadone. What do you say to that patient that does not want methadone?
So if I can understand the question exactly, I would say that I don't know if most are IV drug users. I would say that that's something that needs to be weighed. I think a great resource, and I'll give a shout out to opiate treatment programs because most OTPs, opiate treatment programs, and people like to call those methadone clinics, actually don't just only do methadone, they'll do buprenorphine as well. And they can have those conversations. A good reputable OTP is going to have that conversation with the patients like, listen, I think methadone might be the best medication for you in this situation because of your heavy IV drug use. If the patient says no, it doesn't mean, well, we don't have anything to offer you. That doesn't make any sense. We can still offer them buprenorphine in that situation too. And then you can kind of weigh and see how that goes. There is an upper limit of buprenorphine you can use, and if they're still struggling at that point, maybe there's another conversation that needs to happen about possibly even transitioning into methadone. Hope that answered the question. Just another piece of that, just to kind of weigh in on that, is buprenorphine. It has a pretty high affinity, and it really attaches, when you're around the 16 milligram range, you're probably attaching to somewhere between 92 and 95% of the mu receptors. So you're getting quite a bit of coverage at that situation. And so oftentimes, even in the IV heroin users, you can get pretty good effect in regards to that. So it can be highly utilized too and beneficial in that patient population.
Can you comment on opioid use disorder in the ED for pregnant women?
Yeah, that's a great question. So we talked about those 3 FDA-approved medications are the buprenorphine, methadone, as well as naltrexone. Naltrexone is not appropriate for pregnant women at this point. So we go back to methadone and buprenorphine. The long-standing medication of choice for pregnancy has been methadone. There are a few places in the country that will initiate methadone in the ER, but they've had some pretty long-lasting relationships with an OTP that may be attached to that system in a sense, and they can do that. They have certain protocols to do that. So if you have a system like that, you could actually start methadone in an ER setting, and that would be a safe medication in pregnancy. Buprenorphine is also safe in pregnancy. And I think that's important to understand, but to initiate buprenorphine, you want to make sure that you're not going to create a precipitated withdrawal, right? Creating those withdrawals can be quite dramatic. And specifically in pregnancy, we give buprenorphine without the naloxone. And I don't really think the naloxone is necessarily any type of teratogenesis, it's not teratogenic, it's not going to cause birth defects or so. Really the big push behind not giving a pregnant woman that combination of buprenorphine and naloxone is in the case that we don't want to have a situation where they actually might shoot that up IV. Because if they do shoot that up IV, the naloxone is active, they have precipitated withdrawals, which is very bad for the baby at that point. And so really what we use is the mono product that's called buprenorphine. The brand name for that is called Subutex. And so we'll start that. And oftentimes even in the ER, because again, the naloxone part of this is there just to deter IV use. That means we deter having it on the streets, right? So you can actually give just plain buprenorphine in the ER, and oftentimes it can be less expensive. So in your program, if you're able to develop this, and in our house, what we did is we just said, listen, we're going to start buprenorphine, the mono product in the ER. If there's a prescription that's going out, it's going to be buprenorphine with naloxone in it, because that's going to decrease the chance of IV use and decrease diversion as well. But in pregnant women, either methadone or buprenorphine can be started. Buprenorphine, and we'll talk about real briefly, just to fill a little time here, is a neonatal abstinence syndrome. People worry about, oh my goodness, they're going to have a baby that's addicted to drugs. Well, babies aren't addicted to drugs. They are dependent on opiates. Whether they're on methadone or if they're on buprenorphine, there's about the same percentage of patients, babies, that actually have neonatal abstinence syndrome. It's not dose dependent. If you're on 120 milligrams of methadone versus 60 milligrams of methadone, it doesn't matter. There's no correlation between the dose and getting neonatal abstinence syndrome. Buprenorphine, the length of neonatal abstinence syndrome has been shown to be less in moms that were on buprenorphine compared to methadone. But really, it's important to understand that if moms do have an opioid use disorder, getting them in treatment, keeping them stable on a medication, not going through withdrawals is the best thing we can do for that baby. And so we don't encourage people to be discontinued off their medications at that point. We want them to continue on that medication that keeps them stable, not having those chances where they're going to have those relapses, which can be absolutely detrimental to them as well as their baby as well. Okay, that was a long answer, sorry.
What about kratom used as mat?
Yeah, kratom is, what the heck is kratom? Well, it's whatever anybody wants to kind of put in it. And if you've read the recent literature and really the news, basically there's a high risk with kratom use as well. And there's been some overdose deaths. I have had patients in clinics that have tested positive for methadone, new patients to a methadone clinic that tested positive for methadone. They're like, what are you talking about? I don't take methadone. I've never taken methadone in my life. Well, what do you take? I take kratom. Okay, well, what's in the kratom? I don't know. I got it at this store, and they said this one's really working. Everybody likes this one right now. Well, lo and behold, guess what? It has methadone in it. So people can create these things. They're not FDA, really approved, obviously, but they're not regulated as well. And so you really don't know what you're getting in that situation.
Okay, peer support specialists in many settings appear to be given a great deal of clinical duties, and as licensed clinicians, this continues to trouble me. Just because agencies can bill for them does not make them a qualified clinician. What are your thoughts?
Yeah, I actually don't know how to answer that question, but obviously the hospital is going to allow peer support specific roles, and they can regulate what they can and can't do, obviously. There are some hospitals that don't want to have peer support in there because they can't pass the background check. Why? Well, because these are folks that probably have had some criminal activity in their life, and because they had an opioid use disorder. So I think it's important at least to have them. I have a friend of ours, Dr. Palm, who has a great program, and instead of the hospital hiring the peer support, their agency actually hired the peer support, so they would go in and be kind of an adjunct in the hospital. So they were not hospital employees, and I think that was actually fairly beneficial. They had some pitfalls, and I think had to learn the hard way, but I think that was the way that they decided to go to maybe address some of those challenges as well.
Okay, I have just two more questions, and then we'll conclude. Are you using these processes in your ER, and can you share what your experience is related to repeat visits?
So I don't have specific data at this point. I've given the education out to all of our medical providers. They've had protocols put in place. We've gone and we've established relationships with people, community resources in our area that we can refer patients to, and that's a big piece of that. Making sure that, hey, this is what we're going to do in the ER, and we want to be able to send our patients to you. And we've had just huge, an outpouring of, yes, we will help you. We want to help you do that. And so when you get that kind of buy-in, you start establishing those relationships. That's really a big deal. Giving the education out and actually showing them how it works exactly, and being that person that says, hey, listen, here's the situation. I'm going to go ahead and start buprenorphine, and then sharing that with the rest of the staff to get to see the benefits from that. Do I have peer support? Not yet. I'm still working on that, but just because I don't have that doesn't mean I can't start my program. I had to start somewhere. And so, giving those harm reduction strategies, making sure they're going to have a Narcan script or a naloxone script in their hand, and making sure they know what resources to go to, and letting those resources know that they're to be expecting patients. Maybe we have that phone call saying, hey, we have an appointment for you tomorrow. I just talked to the provider over next, down the street, and they said they'll see you tomorrow. That's a big win, obviously, for that patient as well. So.
Thank you, Dr. Stavros, for your time and your expertise. We have a couple of items of business before we can conclude. When I conclude today's webinar, your browser will take you to the evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be Messenger at WebEx. Evaluation will close at midnight on Tuesday, April 30th. We do not email statements of credit. Instead, we verify attendance and completion of the evaluation. A statement of credit will be generated as a journal entry within your profile. Thank you again, Dr. Stavros, for presenting today. And thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.